So good evening and welcome to Healthcare Disparities in Pediatric Mental Health, Culturally Informed Care. And I'm Karen Coate, the Director of Mental Health Education here at Eastern AHEC. And this webinar series is a part of our Child Mental Health and Primary Care Project, which is funded through the NC AHEC. I am very pleased to introduce Dr. Angela Trombley. Dr. Trombley is the director of the DNP program and an assistant professor at Western Carolina University. She's also the co-founder, administrator, and a mental health nurse practitioner at Prospect Behavioral Pediatrics and Psychiatry, where she provides direct patient care to children, adolescents, and adults. She received her Doctor of Nursing practice from the University of Missouri, and she's board certified as a family psychiatric mental health nurse practitioner and an adult psychiatric mental health nurse practitioner. So please welcome Dr. Trombley.
I am so pleased to be here today. This is such a passion for me to talk about pediatric mental health in general, but then particularly about healthcare disparities. It's something that I've seen clinically and I've been learning more about, something we need to learn more about, and there's just a massive amount of work to be done. But I'm going to share my slides here and some of my experiences, and hopefully share some of the considerations for taking care of children in relation to cultural challenges. So I have no conflicts of interest for this presentation. So I'm going to be looking specifically at some healthcare disparities as they relate to pediatric mental health diagnosis and treatment. I will be reviewing ADHD as it relates to these challenges and depression, and talking about some of the treatments. Some of this you may have heard before in some of the other presentations, but I'm going to relate these concepts to cultural and healthcare disparities with children. I'm going to be considering the screening and the evaluation, and then the diagnostic considerations when it comes to these challenges and healthcare disparities, and then looking at pharmacological and non-pharmacological strategies as I move along. So to begin with then, as we think about ADHD, just a little bit of a brief overview, and I'll be linking this to healthcare disparities, is that ADHD is well known. It's the most prevalent neuropsychiatric disorder in childhood. Typically, though, we do understand that the data shows us that it's generally still underrecognized and underdiagnosed in most countries. We do know with ADHD, it can be very disabling and can have some deleterious effects on the function of the child, the family. Thankfully, though, we have numerous evidence-based treatment modalities and medications primarily, and supportive therapies that can help children with ADHD. So there's a lot out there that can help. The thing that we need to understand is that we do need that appropriate diagnosis so we can get that targeted treatment, and that there really are detrimental consequences associated with not having appropriate treatment. What we understand when we think about ADHD in relation to cultures is that across cultures, really the prevalence is the same. So there's no difference. But what we do know is that there are significant healthcare disparities. And we know, and the data shows us, that with Black and Latinx Americans, there is many less children diagnosed and treated. So certainly for us to be able to promote equitable healthcare, it is essential for healthcare providers to be able to have an understanding of that prevalence and really diagnose these treatment, certainly some of these barriers, so we can look to treat all children. Just a little bit of background, we know ADHD is very complex. There's an interaction between genetics, environment, some considerations for abnormalities in brain function. When we think about ADHD, we know that the neurotransmitters involved are dopamine and norepinephrine, and they just link so directly to treatment because we know our psychostimulants, which are gold standard treatment, directly affect those neurotransmitters. When we look at brain function and structures, again, this really does show the complexities. We understand that in the frontal cortex And particularly in that prefrontal cortex area, there are some significant challenges that contribute towards problems with cognitive function and impulsivity, hyperactivity, processing of information. Particularly, I did want to point out, as it relates to ADHD and potential for misdiagnosis with some children, is that there is a significant relationship between emotions and attention and hyperactivity. There's a particular loop called the cortical thalamic striatal cortical loops. And what that is, it's a complex structure in the brain where a child will have significant emotionality, and it will also include hyperactivity. And often clinically, this may be seen as tantruming, violence, mood challenges, frustration, intolerance. It can get a lot of attention and can be very challenging to manage. And this particular part of ADHD often can lead to misdiagnoses in some children, particularly because it's seen more as a behavior problem outside of ADHD. And I'll explain that a little bit more when we think about different cultures. But it's important to know that, of course, ADHD can include some significant behavioral challenges. This just shows a brain map. You may have likely seen this before, something like this before, that shows the challenges with executive function and metabolism through mapping of the brain. So significant alterations in a child with ADHD. So when we think about diagnoses, so we get to a diagnosis, it's supported clinically often with communication. We talk clinically to identify symptoms. We have to think about history. We talk to parents, teachers, talk to the child, observe children. We may want to get information from the school, some collateral information, some caregivers. So they can be some kind of quite interactive and should be kind of collection of information to be able to come to a diagnosis. Sometimes we can use tools to help us, so roundabout screening, Conners screening, that can help provide information. Of course, with screening measures, that's all they are, and they can provide information, but then we have to always think about interpretation, language, and understanding. So that is something that can be challenging culturally, and I'll describe and talk about that a little bit later. But generally, the role of diagnosis is to rule in or out other issues and look at strengths of that child, and then work on that therapeutic alliance so we can hopefully get an accurate diagnosis and targeted treatment. This is just a slide identifying the different treatments, and it's important to understand, especially in relation to what I'm talking about, is that there are so many treatments. Effective treatment, the efficacy of psychostimulants is really, it's fantastic, it's wonderful. And when you treat a child with ADHD, it is an amazing thing for the functionality you can provide for that child and that family. And so then when we think about the prevalence of ADHD being the same across cultures, having these wonderful ability to diagnose and treat, it is then really a hard concept to think about that this is not available for all children. Additionally, when we think about ADHD, there are some behaviors that can cause some significant challenges. So these children often will be involved in fights, and there's the impulsivity, the aggression. Again, I explained where that comes from. This can lead to delinquent behaviors, maybe in adolescence, and it can unfortunately lead to substance use, and these children are more at risk for substance use. In the school, what we can sometimes see is low academic performance, difficulty reading, writing, low achievement, and it's not associated with IQ. It's not IQ, it's just the fact that there are significant challenges with the processing of information, and it might be certainly hard to concentrate if you just kind of keep getting distracted. And so over time, left untreated, this can lead to significant challenges with confidence, anxiety, depression, suicidal thinking. I've seen a lot of that in relation to ADHD. And then they can be, because of some of the behavioral challenges, that counterproductive kind of behavior. So when you get a negative feedback, you just why would I bother to try, because everybody just thinks I'm that child. And so then we get that kind of given up almost over time. It's important with ADHD to understand the lifelong trajectory, because you need to understand that really to understand what non-treatment means. It's not just non-treatment in childhood. It's not just non-treatment and the child might not get the best grades. It's a lifelong trajectory. And so we're talking about then the continuation of ADHD, which as an adult can lead to challenges with cognitive function, which can lead to problems with finances, jobs, relationships. Definitely there's a link to increased criminal behavior, certainly comorbid disorders, mood disorders, and substance use that I've already mentioned. What we see then is that when there's earlier substance use as well, there can be then, greater risk for hospitalizations, comorbidities, suicide attempts. Significant risk and harm can come from non-treatment. There is some concern, has been historically, that, psychostimulants can lead to substance use, and people will say that to you clinically. You'll hear of that fear, but really it's the opposite, that it's protective to treat. And so certainly we need to be doing this and thinking about this. Non-treatment is significant. So then kind of going back to racial and ethnic disparities and healthcare disparities. So despite what we know, we do know also through the data that there's a significant less amount of treatment or even a diagnosis and treatment of children from different cultures and compared to their white counterparts. So specifically in some of the data, we see that even though we understand the prevalence, the amount of children, Black children or Hispanic children diagnosed is significantly lower. If there is treatment normally lasts for a much lesser amount of time. Typically, there's not continued treatment. And then we do know as well that there are significant challenges with language. So in a non-English speaking household, even though symptoms are presented the same kindergarten, and one research identified that there's still significant decreased amount of referral to treatment and treatment. And so what we do know with that is when we have this level of underdiagnosis, it prevents those valuable school accommodations. So there are accommodations. It's not like we don't have these things, and you'll hear of 504 plans and various strategies, but these children, because they're not diagnosed, don't have access to these things. And so that can affect, academic support and performance. And of course, we'll start on that kind of lifelong trajectory if we don't catch and treat these children. So why are we in this place? So it's really important to know why. So the data and research is identifying that we still unfortunately have significant challenges with racial bias in the classroom and then a judicial system. So unfortunately, that is something that we need to address. There can be sometimes a general lack of awareness about ADHD in some Black families, and then sometimes significant limitations in social networks. Sometimes there can be also challenges with being underinsured and limitations financially, access. So all of those challenges can prevent appropriate treatment. Also, there is the stigma as well. Sometimes there can be stigma and there can be misperceptions about the behavior. Sometimes from a family that might think that this is more of a family problem, that they need to manage the behavior. And then sometimes, certainly among teachers, and I talk a little bit more about that moving along. Sometimes as well, there can be a fear of the treatment, which can sometimes prevent moving forward with evaluation. We also see some significant problems with our healthcare system. And so this is something that we really need to embrace and recognize. There has been a significant level of distrust in relation to discrimination. There has been challenges with a history of misdiagnoses. I see that now quite frequently. And then a fear of treatment. Certainly, other significant challenges can be differences with bonding with teachers and communication with teachers can be a challenge. So these children aren't particularly identified as having ADHD symptoms. They're more identified with having behavioral problems. So sometimes as well, there can be a lack of congruence between authoritative figures and the child, and sometimes even in that communication with parents. Sometimes a misinterpretation from teachers of assertive self-expression is cultural, and that can be misinterpreted as a behavior trait, both for the child and sometimes for the parent. And all of these things can limit children getting appropriate treatment. This is a particularly hard concept because what we're starting to look at is the result of some of this non-treatment and non-recognition of ADHD in children. So there is the institutional racism and that school to prison pipeline. It's really important to understand what happens to these children when they're not recognized. And so what we see is there's a significant negative effect within educational systems for Black children generally. This is thought to be one of the reasons this contributed towards underdiagnosis of ADHD compared to white children, and it leads to significant social injustices and certainly a trajectory for that child that is very different to what it could be. Another consideration of this was, has been policing in schools, which has also contributed towards racial discrimination. I did want to, within this, share a case that I knew about at the time, but in Mississippi, there was a case where 77 Black children were arrested and put into juvenile detention center, and they did not have any of their rights respected, and they were arrested immediately upon having what was considered to be minor infractions. So they would be engaging in what was considered or seen to be disruptive behavior, leaving the classroom without permission, being tardy, maybe having what was considered unruly behavior. There were no violent behaviors reported, and these were very much considered to be related to symptoms of ADHD, but these children were taken immediately to juvenile detention centers. So it shows just that level of bias that was happening in that school and just completely inappropriate management of what they were seeing. What we know from this is that when you introduce a child at a young age to the criminal justice system, they've got a much increased chance of having a reoccurring engagement with the criminal justice system. It definitely can lead to risk of dropout of school and prison when they get older. So right there, if we're not managing behaviors appropriately and seeing them as mental health challenges, then you're literally changing that child's trajectory in life. So according to the US Department of Education, civil rights and for Black children, they're more than likely to be expelled or suspended from school than white children. And the overpunishment is very much considered to be a result of underdiagnosed ADHD. And what we see is that, it just absolutely limits opportunities and learning in school. So this study, I was very much sad to see it, but it's the reality. It's a study that was done in North Carolina State University. And what it looked at is racialized, anger-biased against Black children. And what it identified is that teachers were more likely to interpret facial expressions in Black boys and girls as being angry and that was significantly different to white children. So that's how they're being judged from the outset. And, there is certainly risks of then disciplinary discrepancies from that. They noted some challenges of that misperceiving anger. And it definitely, this study highlighted the need to address, what we know as conscious, but then that unconscious bias in educators. And of course, children are in schools. And so when we're talking about ADHD, cannot talk about that without talking about schools. So it was definitely considered that the misperceiving of the anger could play a significant role in the disparities and contribute towards, again, children being suspended and, behavioral actions against Black children, which is, significantly sad. So let me go back actually to that last slide. So one of the challenging things with this is that I saw this clinically way before I noticed, anything in the data. And I was seeing very commonly in Black children that would come to the clinic that they often were misdiagnosed, they often had inappropriate medications, and they were already facing significant challenges with DJJ or some level of punishment or charges versus appropriate treatment. One child in particular always sticks out with me when his aunt come in one day, just so upset that, if we didn't see this child, she was frightened that he would go, or the threat was there that he would go to alternative school. This was a 7-year-old. And I was due to see this child in about 3 months. This was in the outpatient clinic. And she was just like begging the front staff, can we please see him sooner? So I saw him, I had opening, I saw him that afternoon. And he, when I got him from the waiting room, clearly his little leggies were moving and he was definitely fidgety. And come back to the room, and just the most amazing, delightful Black boy that was just looking at me, kind of not knowing what to expect. And what was the story from the school, or what was being reported from the aunt, that he was having significant behavioral problems, they couldn't control him, and he was down to, I think, 1 hour a day at school, and he was about to go to alternative school. He did not have a 504 plan, and then he was being treated by someone, but it was with Depakote. So when I talked to him, and he gave me some great criteria, I talked to him and he told me how he had trouble paid attention focusing, and that he would sometimes say things when he was meant to be quiet. He had a hard time staying in line, would sometimes kind of get upset, and he might nudge another child or kind of push another child, which got attention, and that he found himself in the principal's office and was significantly worried about having to leave that school. He was a great historian. He told me a lot about his ADHD symptoms. So with evaluation and kind of looking at, perhaps maybe a little bit different, he definitely was ADHD. Now, whoever was giving him Depakote, what we know about ADHD, again, the norepinephrine and dopamine, it was never going to help him. Depakote does not work in that way. And in fact, it could have been making things worse, because it could make him tired, sedated, and kind of slow cognition. So even though he was getting some level of treatment, it wasn't the right treatment at all. And the target was behavior versus really his diagnosis. And so very quickly, I was able to get him on appropriate medicine, called to school, provided some education to the teacher. We got a plan, 504 plan, and he is just doing amazingly well and still is about 6 years later. The thing with him, and I've seen many children like him in different stories, but the same kind of theme, is that what would have happened? What would have happened? And what would have happened to him if he'd gone to DJJ or alternative school? It's just sad. And that's something that I always think about. And this is seen very frequently. So moving on a little bit, and then towards the end of this presentation, we'll talk a little bit about what to do. The big take-home point with ADHD is the fact that treatment, we've got it. It's right there. It's great treatment. We're just going to get it to those children. I'll talk a little bit more about that later. So moving on to some other things we're seeing a lot in pediatric mental health. So certainly suicide is becoming a very significant problem. I mean, it was prior to the pandemic, but now we're seeing some very significant increases, and it is quite alarming. We are in a mental health crisis, of course, for children, and we're seeing that with the acuity of children that need help. So some significant risk factors associated with suicide in children, certainly age, ethnicity, race, gender, exposure to media, relationships, trauma, significant factor, interpersonal violence, history of maltreatment. So there's lots of risk factors. When we think about trends and what we're seeing, we do know that, again, pediatric suicide is unfortunately rising. And we're seeing that, and this is a very significantly challenging concept to think about, that about 50% of adolescents actually do kill themselves on their first suicide attempt, 50%. So of course, the thing with knowing that is you've got to get in there before. It's that prevention, got to be identifying people. So we do know that most children that will try to kill themselves have a mental health disorder, usually depression. And certainly there are other factors like impulsivity, and then feelings of self-doubt and uncertainty. And certainly our adolescents have had absolutely more than they should ever have experienced of those kind of feelings in relation to the last couple of years. We do know here in North Carolina specifically now that suicide is the second leading cause of death in North Carolina for 15 to 34, second leading. So a lot of our pediatrics in that bracket. And then at the third leading cause of death for children, 10 to 14. And sadly, we're seeing children way younger than that presenting or post-suicide attempt. It's just very, very sad. There are some specific considerations. Certainly the ACEs study has identified that link to or consideration for adverse childhood experiences. And it's typically found that the more of those there are, the higher risk for that child. And then, of course, when we have considered maltreatment, particularly with sexual assault, again, there's an increased risk. And what we know that when there's exposure to trauma, what we're seeing now is that there are neuro changes that sometimes can't actually be reversed. And then when children have these experiences, they're much more at risk for kind of chronic reoccurrence of their symptoms, hospitalization, and it's generally harder to treat. So again, this all points to identification. The pandemic, I've mentioned this already, but definitely we've seen some significant changes. Again, we had that loss of peer interaction, socialization, and supports. And the school, plays a major factor for many in services. So what we also noticed, it was considered about 80% of children do rely on school for school-based services. And so when that wasn't there, that was a significant challenge for many children. Now, relating some of this and that I've just talked about with depression and suicidal thinking to racial and ethnic disparities, what we see is that on top of a very challenging situation, I mean, the statistics are just devastating that we're in this place. We then have further challenges. So it's like a layered approach where we have even more challenge for these children. So what we see is that often there's limited reporting by some children, some cultures, and certainly it's been identified with Black adolescents. There is concern that we're just not capturing either clinically or in research because of limited reporting. We do see that we've got limited culturally, again, sensitive treatments and the bias that can, again, lead to these challenges. What we see is that, again, there's discrepancies. So we would ADHD and now kind of depression, suicidal thinking, there's discrepancies in children that are treated versus not. And it is a disproportionate amount of Black youths compared to white youths that are identified and treated. And some of the reasons for that, again, is the way that we evaluate maybe and our understanding of some cultures. So it is identified that sometimes with Black children, the expression is different. So we have to be very careful. You know, we have to be careful with our screening measures and then with our questioning, and because it might look differently. So we've got to be aware of that. There may be certainly different descriptors used. And what that does is it means that, of course, these children are not going to be identified. And so significant challenges there. So actually, before I get there, I'm going to go back a little bit. So clinically, what I have seen with this factor is the fact that when we don't capture these symptoms, again, sometimes what we see is more behavioral challenges. So I do see a lot of Black children that might present to the clinic, and there may be other diagnoses, and it's important to kind of know that limitations in evaluation can lead to, again, sometimes very inappropriate treatment. So sometimes certainly there's use of mood stabilizers again, and second generation antipsychotics, which have way different side effect profiles to antidepressants, and certainly further create challenges for these children. An example that I have is a 16-year-old Black male that I was taking care of that comes to the clinic. And when I met him, first he didn't want to talk to me, and I agree with him. I said, I understand why you don't want to talk to me. I'm tired of people like me. And he'd been removed from his home with his mom, about 5 or 6, lived with grandparents, and really just had this sequel of hospitalization, treatment, behavioral discontrol, and diagnoses. The diagnosis he came to me from a hospitalization was a psychotic disorder, and he was on Seroquel. And it took a long time to get the evaluation done. I had to go way back. I mean, we had to work on trust. First thing I did was validate him not wanting to see me by understanding that I probably wouldn't want to either. And then we worked on the relationship, and I listened to him and his story. And what really seemed to happen was that when he was taken from his mom's care, he had the behavioral challenges. What he was experiencing was depression. He was depressed. He had significant adjustment disorder, and he also had significant anxiety. And at night, he couldn't sleep, and he was frightened of the dark. So he would see things and shadows and things. And really, his diagnosis, back then was adjustment disorder, anxiety, and he needed a lot of therapy. What he ended up with when he saw me was this, various mood disorder diagnosis and psychotic disorder. The Seroquel that he was on had gained him 100 pounds. And amongst some of the things that we did, I identified, he had sleep apnea, hyperlipidemia, he was pre-diabetic. And amongst, the treatment, which included getting on to more appropriate medication, Prozac versus Seroquel, very different. Get him off the Seroquel, we had to work a lot with other things, like health-related things that were literally side effects from the Seroquel. And to me, that is just a very high price to pay for a child who essentially was missing his mom and scared at night, scared of the dark, and very likely unable to describe or express that. So I wish this was isolated, but it's not. And I see it very frequently. And I think it just talks to the need to separate out some of the bias and judgment, and I'll go into that a little bit later, but also that the expressions of mental illness and symptomatology may be different. And so there's a great need for us to increase our knowledge and really help these children to avoid some of that misdiagnoses and certainly inappropriate treatment. So what are we going to do? So a little bit more about what can we do? So one of the things certainly that's been identified, it's just probably no surprise, is that collaborative care model. I know a lot of organizations are working towards that, and they really can be very helpful in helping with some of the challenges. So for example, if we need help with language, if certainly some other supports needed for the family, that collaborative care model can help. So again, we're looking at that holistic piece, not just one psychiatric eval in a standing clinic. You can hopefully have all of the things, and collaborate as part of a team. And it's often very much needed. You need that help from either a caseworker, social worker, to help navigate through this system that's very challenging. So those models can be very helpful. We also have some models that can help us with how we evaluate. And so a lot of it is misinterpretation, or just kind of not identifying symptoms with diagnoses versus kind of behavior, mood challenges. And so this particular model here, the ethnic model, is one particular tool that can be used for ADHD. And it does help to get that cultural perspective and evaluation, and kind of hopefully help a clinician or provider identify symptoms that may not be seen because of limitations with either expression or understanding. So some tools that can help us. Even in the DSM, there is some part that provides or acknowledges these challenges. So there is the cultural formulation interview. So that could be a helpful tool to allow providers to have a structured way to evaluate somebody. The goal of this particular tool is to look at a person's cultural identity, explanations or experiences with mental or illness, cultural interpretations of stresses, supports can be a very important level of function. Again, in some families, it might be seen as a parenting challenge versus symptoms of ADHD. And we can help with that kind of challenge so children can get treated. There is a lot of sometimes blame or burden put on the parenting versus this is, a neuropsychiatric disorder that's treatable. So we can help with that. And then that element, that cultural element and understanding with that clinician relationship. So of course, the goal of this particular formulation or interview is that we would avoid stereotyping, help providers understand the patient's view of the illness and how they might seek help or view treatment. What we do know, of course, is that if there are problems with these things, so if there are issues with that relationship, then the likelihood of that child coming back is they're not going to come back. And so we have to, if we get that child in care, if we can get them, screened and into, a care environment, we need to engage in a way and interact in a way that will encourage that person to come back. So there's loads of, other considerations. And although we are, say if you're working in your zone as a provider, often there's a need with children to reach out. And so that's something that, certainly we should be doing in individual cases, but then education whenever we can, because there is a significant gaps in education, which I identified just in a recent study in North Carolina, and that misinterpretation of anger. So education in schools, we really do need to help with that. And I've definitely helped teachers with the way they're viewing children or interpretation of behaviors. We know often with children that if there are challenges with anxiety and depression, that can sometimes also be seen as a behavior and expressed as a behavior. And so we need to make sure that we're informing or helping teachers with education so they know to look out for other symptoms and consider other symptoms. And so we need to also be considering understanding the disparities, and that the school is such an important place for these children to be identified. And then certainly that awareness of inequality in school and bias. I mean, we're just, I think, at the beginning. I know some schools are certainly working on cultural competency, but there's definitely more, because we're still seeing significant challenges. So when we need to, again, certain thinking about interventions, engaging in activities that can help reduce barriers is exceptionally important. Looking at the data, again, the stereotyping behavior are all significant factors. One thing that I did want to look at is maybe some more kind of progressive data that we're seeing now. So there's lots of research recently, because what we're noticing is that actually we have got interventions and there have been policies and there has been some level of reform, but we're not seeing the benefit yet to these children. So there's a need to explore really why. We do know that there are certainly challenges that are kind of more holistic. So a thing that we need to think about is all of the challenges that might be presented for that child. So socioeconomic status. So I talked a lot about that with risk factors. So is that a challenge? Do we have a diverse work environment? Again, there's limitations in trust and historical challenges with misdiagnosis, mistreatment. So how are we going to help encourage somebody to come? And having a diverse work environment would definitely be a consideration. We definitely need to look at programs that reduce stigma, look at where we are with discrimination and acculturation, and what we're seeing with, again, the research that's coming out. Something that struck me was the labeling again. So going way back to the beginning when I was talking about ADHD, the misinterpretation of ADHD symptoms, and how that can really affect interpretation of symptoms and then diagnoses. And certainly it's considered that when a child is labeled aggressive or a problem, that can itself become a self-fulfilling prophecy. So we're creating problems, and what it contributes is just to that delay in treatment and cognition, and certainly that diagnosis. So it's that judgment that needs to be improved. So to end with, then, there are definitely strategies that we can use in our work environments. We can look at more holistic, culturally informed screening measures or evaluation measures. We can look at increasing diversity. That definitely needs to happen. We can look at communication and language and how that might be a barrier, and more of that kind of collaborative care approach. I particularly found this information in some ways just really sad, but informative for what we really do next. And so this particular, I read a research that looked specifically at the improvements or changes, any changes in healthcare disparities for children associated with insurance reform. So between 2012 and 2017, there has been level of insurance reform. There has been change in policies, insurance coverage. But what has been found is, despite these interventions, they have not seen sufficient reduction in disparities, access to healthcare or care in the United States. So it's really sad that when you think about the normal, what are we going to do? Increase money, funding, policies, and it hasn't particularly made a difference. And so the big thing is why. So from a provider point of view, and certainly from my point of view, when I see so many children that are not treated in the way they need to be, or have had changes in their school function because of misdiagnoses, there is definitely a need to know why. And of course, having that wider understanding of that risk for a lifelong trajectory. And so what it was considered in the research that occurred is that, yes, again, we need to expand access to include more providers of color. So again, that's increased diversity. There needs to be more research because we're not capturing the information. We're not capturing the children that are feeling depressed. They're underrepresented even in the research. So then it kind of, what can we do? And one of the biggest things that really kind of stuck with me is that improve cultural competence. But all of us have had cultural competence courses. And when we look at that, one of the biggest things I'm seeing now when we think about cultural responsive care is that the exploration of implicit bias. And so we're aware of bias, and I've talked about that in many of my previous presentations. And we need to be aware of our bias, but what does that actually mean? I was involved in a research recently where we took a look at healthcare workers and implicit bias and understanding just how deeply rooted that is. And it's unintentional. It's unintentional, but it is in organizations, it's in society. And when we're thinking about how to reach out to children and really make a difference with healthcare disparities, and we're thinking why, despite policy change and change in insurance coverage, we've not made any ground. I really honestly think, the data is identifying that we need to look at ourselves and the people we work with. And so it is time, really, as providers, for us to look in the mirror and identify what our bias are. Do we have implicit bias? Is there implicit bias in the organizations in which we work, in the societies? And we need to do that so that we can reach out to these children and form appropriate and trusted relationships. We need to do that so we can truly understand people from different cultures. And really, there is a need to make this change so that we can provide culturally responsive care. So it's more than culturally competent. That's not really cutting it anymore. We need to be aware of the types of biases that keep this problem with healthcare disparities happening despite the interventions and supports that have been there. We definitely need to do that, and especially in relation to children. All children should have access to the medicine that's readily available. We've got great abilities to treat, but we cannot do that if these children aren't identified. So we need to be able to see children and respect them and their families, and definitely work towards being able to provide these services to all children. So I think the biggest tool, if you like, for today, and certainly for me in doing this research and some of the readings I've been exposed to recently, and even with identification again of how teachers view Black children and the misinterpretation, is that it's kind of time to look at ourselves. And that's really, I think, the biggest tool to leave you with today.
So, Angela, there is a question for you. And thank you very much. That was great. One of the slides mentioned very high rates of depression for Latinx teen girls, and we see that in our practice. It seems that culturally, these families do not accept mental health diagnosis or treatment well, and are often not interested in therapy. Are there any resources to help us take better care of these children?
And they definitely, we see that as well. I think really often what it comes down to, with me at least, is there are the cultural barriers and perceptions. And then sometimes what really helps me, and this practice is, I take it down to a brain level, neurotransmitters, what happens with depression, and what can be a consequence of that, kind of more like that education, but a very scientific kind of education. And that seems to be very helpful. You know, I often find that people can relate to that as a kind of science-based approach, and then the risks of what might happen, and then the data being the facts. And so if you're thinking about, you know, if there is kind of resistance to treatment, that can sometimes be helpful in just kind of supporting people within that. And sometimes I find as well that if you provide, you know, certainly, you know, think about language barriers as well. I provide information in different ways. So verbally, you know, send information home can be very helpful as well. So I don't know, have you tried any other interventions maybe? I can't see the chat, so I'm not sure.
Not that they've put in the chat.
Okay.
But Kathleen, if you want to unmute, that's fine. If you want to unmute and answer, that's fine with me. Oh, Kathleen said it's very difficult in primary care to spend that much time with the patient. Yes.
That is a big, big factor. And I honestly, I can't imagine having such a short amount of time. And we've talked about having that collaboration maybe with psychiatry, maybe consulting. I don't know if that's an option. Having embedded therapy might be an option that can help some people.
Kathleen also mentioned that they're struggling with limited providers, unfortunately, especially that speak Spanish, which I'm sure is an issue for many folks.
Yeah. Yeah, we've seen that. And then even like therapy services are fairly non-existent at this time, even where I'm from in Asheville, it's very, very hard. And especially therapy that provides care for people who need interpretation services.